Welcome to The Explainer. Today we're doing a deep dive into an organism that every microbiologist knows, and let's be honest, sometimes struggles with, Streptococcus anginosus. This is a bug that truly lives a double life, acting as a harmless passenger one minute and a seriously aggressive pathogen the next. It's one of the great chameleons we deal with in the lab.
So let's just get right to it. We're talking about a classic double agent. It hangs out quietly on our mucosal surfaces, totally harmless. But you give it half a chance to cross that line, and it transforms into this incredible pus-forming invader. It is, without a doubt, a true master of the abscess.
For this explainer, we're going to follow that classic lab bench to bedside journey. We'll start with its identity and the taxonomic mess that used to surround this organism. Then, we'll step into the lab to see how we unmask it. After that, we'll look at the pretty scary diseases it causes, cover the absolutely critical treatment guidelines, and finally, we'll talk about how to keep it contained in a hospital setting.
Okay, first up, let's tackle this identity crisis. Because, the historical confusion around Streptococcus anginosus wasn't just some academic debate. It really held back our understanding of just how dangerous this bug could be. For decades, everyone just called it Streptococcus malariae, but that name was, frankly, a mess. It was this big umbrella term that lumped together different organisms, which made the research incredibly confusing. It wasn't until modern molecular tools came onto the scene that we could finally, definitively, separate them out into the three distinct species we know today: Streptococcus anginosus, Streptococcus constellatus, and Streptococcus intermedius.
All right, let's head over to the lab. This is where we really see why this organism gets that chameleon nickname, because it can be incredibly tricky to pin down.
The diagnostic workflow is kind of a funnel. It starts out broad with the basics, your gram stain and culture plates, but to get the definitive, species-level answer you really need for this group, you almost always have to narrow it down to the precision of molecular methods.
So on the plate, the thing that drives everyone crazy is its variable hemolysis. It can show up as alpha, beta, or even non-hemolytic, which means it can look like a whole bunch of other streptococci. But here's a pro tip. For the experienced tech, that distinct, sweet, almost caramel-like smell can be a massive clue that you're dealing with something in the Streptococcus anginosus group.
Now, when we get to the biochemicals, this is our first real shot at telling the three species apart. You'll notice they're all Vages-Proskauer positive, but the real action is in the other reactions. How they handle arginine hydrolysis and ferment sugars like lactose and trehalose, that's where we start to see the separation. It's our first big clue, but it's often not the final word.
And this right here really sums it all up. Relying on phenotype alone is a bit of a gamble. Conventional methods are a decent start, but they can be slow and sometimes just plain wrong, because this bug is so variable. For the kinds of serious infections this group causes, we need the speed, sensitivity, and species-level accuracy that, really, only molecular techniques can deliver.
Okay, so we've figured out what it is in the lab. Now let's talk about the clinical impact, because this is where that accurate lab ID becomes so critical. The Streptococcus anginosus group has a very clear and very dangerous specialty. Here's the bottom line. When bacteria from the Streptococcus anginosus group get into places they shouldn't be, they don't just set up a simple infection. Oh no. They come armed with enzymes that literally destroy and liquefy our tissue, walling it off into collections of pus. They are master abscess formers.
And this is why that species-level identification we were just talking about is so much more than an academic exercise. Each species has its own tendencies. If the lab calls you with Streptococcus intermedius from a blood culture, that's a massive red flag for clinicians to start hunting for a deep abscess, especially in the brain or the liver. It gives them a huge diagnostic head start.
And the list of damage this group can do is just staggering. It can be anything from skin abscesses all the way to life-threatening infections in pretty much any organ you can think of. The liver, the brain, the lungs. It can also cause a really, really destructive form of endocarditis.
So given how aggressive these infections are, how in the world do we treat them? Okay, this next section is absolutely vital. We're going to cover the core principles, some tricky details about susceptibility testing, and what the guidelines say. Before we even whisper the word antibiotic, let's get one thing crystal clear. The single most important rule is this: you must drain the pus. It doesn't matter if it's a small skin abscess or a giant one in the liver, source control is completely non-negotiable. Antibiotics just can't get into that collection, and treatment will fail if you don't drain it. Now, for all my fellow lab people out there,
This is probably one of the most critical takeaways of this entire explainer. When you're doing susceptibility testing on this group, you can't just use one standard breakpoint table. According to EUCAST, the correct interpretation depends entirely on the hemolysis you see on the plate. Getting this wrong is a major, major error.
So here's the rule, plain and simple. If your isolate is beta hemolytic, you have to use the breakpoints for groups A, B, C, and G strep. For everything else, the alpha or non-hemolytic ones, you must use the viridins group Streptococci table. Applying the wrong one could mean you report something as sensitive when it's really resistant, or vice versa.
So if we take a peek at the Dutch guidelines, you can see that treatment is very much based on the Glenickel syndrome. For a drained scrin abscess that has some cellulitis around it, flucloxacillin is the go-to. For something as serious as endocarditis with a susceptible strain, you're looking at 4 weeks of IV penicillin G or ceftriaxone.
Now, international guidelines from groups like the IDSA are pretty similar for endocarditis, but you'll see a key difference for skin infections. They often recommend starting with empirical coverage for MRSA, depending on what your local rates look like. But here's a crucial point they all agree on. Short, 2-week treatment courses for endocarditis are explicitly not recommended for this group, likely because of how destructive these infections can be.
Now, in the pediatric world, where brain infections are a huge problem, there's a really important shift happening. The old way was to keep kids on IV antibiotics for 4, 6, even 8 weeks. Now, there's a big move toward getting stable patients switched over to highly effective oral antibiotics to finish their treatment. It's much safer than keeping a central line in for that long.
And finally, since this organism is known for causing such messy, pus-filled infections, how do we handle it in the hospital to make sure it doesn't spread?
You know, the infection prevention strategy here is beautifully simple and just plain pragmatic. It all comes down to one single question. Can you safely cover the draining wound with a dressing? If the answer is yes, and the drainage is contained, standard precautions are all you need. If it's major, uncontained drainage, then you have to step it up to contact precautions. It's that simple.
All right, so let's boil this all down to the absolute must-know points. First, remember Streptococcus anginosus is a commensal chameleon that's an expert at forming abscesses. Second, for a truly accurate ID, molecular methods are your best friend. Third, for susceptibility testing, you have to use the right EUCAST table based on hemolysis. And finally, and most importantly, drainage first, always.
This whole explainer was put together using a Gemini deep search. If you want to see the full list of sources and really dig into the data, you can check out the linked notebook document. We would absolutely love to hear about your own experiences with this challenging bug, both in the clinic and in the lab. So please subscribe for more explainers like this one, and definitely leave your questions and feedback down in the comments.